Okay, good afternoon, everyone, and welcome to the third CVRN Rising Star Seminar. I'm Sabine, Allida, and I have the pleasure of being the convener of today's session. Before we get started, I would like to first do an acknowledgement of country. I would like to acknowledge the traditional owners and custodians of the land on which we are meeting today, the lands of the Gadigal people of the Eora Nation. I would also like to acknowledge the lands on which our online audience are joining in from. I pay my respects to their elders past, present, and emerging. So before we hear from our first speaker, I'd like to briefly introduce the CVRN. The CVRN was established in 2005 to strengthen, facilitate, and promote cardiovascular research in New South Wales through collaboration. And we do this by developing and supporting strategic events and opportunities such as this to enhance research capability with a particular focus on supporting early and mid-career researchers. So currently, as you can see on the slide, all major research institutes and universities are member organizations of the CVRN, and this includes all the New South Wales local health districts as well. The CVRN has over 600 individual members across research spectrum, from basic to public health researchers, investigating all aspects of CVD, including stroke, diabetes, and kidney disease. So the CVRN is funded by the New South Wales Health and organization membership fees as well, and hosted and supported by the Heart Foundation. So we do have an executive committee that drives the strategic direction, and a Rising Star subcommittee responsible for developing and driving events and opportunities for EMCRs. So this committee is co-chaired by Dr. Alice Gibson and Professor Jamie Vandenberg. And this is what our committee looks like. We do have to update the photos, but yeah, this is who we are. So our seminar today is on the topic of innovations in cardiovascular care, integrating psychology, genetics, and digital health. So as you can see, we have 7 fantastic speakers, including 5 EMCRs and 2 PhD students. So our EMCRs will be presenting for 10 minutes, and PhD students will have 3 minutes. So we'll have a Q&A panel at the end of all the presentations, and everyone in the room are more than welcome to ask questions by raising their hands, same with people online, and also posting on the webinar Q&A function as well. So without further ado, I would like to introduce our first speaker, Dr. Andreea Heriseanu from Macquarie University, and she will be presenting on optimal psychological approaches for cardiovascular disease and mental health. Please welcome.
Hi, everyone. Can you hear me? Okay, great. So thank you for having me today. I'm going to present on some research I've done and also planning to do next. I'm a researcher, but I'm also a clinical psychologist, so my talk might be a little bit different to other ones you might have heard in this series. So let's talk about cardiovascular disease and mental health. There is a large overlap in these conditions compared to the general population, especially depression, which is 5 to 6 times more common in people with cardiovascular diseases than the general population. Those with depression have adverse outcomes compared to patients without depression, including all-cause mortality, cardiovascular-related mortality, and disability. There seems to be a bi-directional relationship such that depression and potentially anxiety play a critical role in the development and progression of cardiovascular disease. And at the same time, those with cardiovascular disease are more likely to develop depression and anxiety. Another problem is that people with depression are 3 times less likely to follow health advice. They're less likely to adhere to treatment based on health behaviour changes, such as diet modification. And those with anxiety are well known for avoiding important health-related behaviours, such as exercise. So why is this important? Health behaviour changes or lifestyle changes are critical for both primary and secondary prevention, prognosis and quality of life. However, health behaviour change is difficult to make and even more difficult to maintain in general. Programs do exist to assist with this. However, referral rates are relatively low and uptake and completion are also quite low, and they don't tend to address mental health. At the same time, mental health interventions also exist, but they're not usually optimised for people with cardiovascular disease or chronic health conditions in general, and don't generally address health-related behaviours specifically. It's also possible that particular people or groups of people may benefit differentially from particular intervention types based on clinical and demographic characteristics, expectancy and preference. What does this mean? So often when we run clinical trials, we have a treatment group and a control group, and we expect that results will look like this. However, they often look like this. So some people get much better, some people benefit a little bit, some people don't benefit at all. And that's probably because people actually look like this. So it's important to look at not just whether your interventions work, but also for whom they work or don't work. It's important to look at a wide range of factors, so intervention type, demographics, clinical characteristics, the presence of or severity of mental health symptoms, and other factors such as readiness to change, expectancy and preference, perhaps expecting results that look like this. This information can then be used to inform psychological and behavioural models of care for people with cardiovascular disease or increased risk. Okay, so I did some work recently to try to understand some of the barriers to using health behaviour change interventions. So these are preliminary results from an online survey in a comprehensive sample of Australians 45 years or older. And the main sample demographics closely resembled national distributions. 38% of the sample had established cardiovascular disease or had been told by their doctor that they were at increased risk for developing cardiovascular disease. And of these, 300 odd people, only 50 people had done some type of health behaviour change intervention. There wasn't really any clear pattern of uptake in this group, as in why some people did and some people didn't. Most of the interventions were for diet, physical activity and weight loss, and most people who participated in interventions found them to be helpful. I also asked people who did not take part in a health behaviour change intervention about the barriers. And most people said they didn't find them to be necessary or important for themselves, and they weren't recommended by a healthcare professional. Other barriers endorsed were cost, physical and mental health, lack of confidence. These were also endorsed as barriers. Then I also asked people about their interest in future interventions with different focuses. So a health behaviour change intervention, a mental health intervention and a combination intervention. More than 50% of people with cardiovascular disease or increased risk said they were interested, and another quarter were unsure, which was a similar pattern of results with regards to endorsing interest across intervention types. I then looked at any associations with endorsing interest in this group. So some factors seem to be generally associated with interest in future participation in an intervention, such as having previously participated in an intervention, which makes sense. If you remember, most people seem to find interventions helpful, the few who participated, and younger age. And the same sort of associations I found for the interest in a future health behaviour change intervention. When looking at the mental health based intervention and the combined intervention, a lifetime history of mental health difficulties emerged as a significant association, and a few other demographic characteristics. So there appears to be some differential interest in different intervention types based on individual characteristics. So what's next? So the next stage of my research is to examine what works for whom in terms of behavioural and psychological interventions for people with cardiovascular disease and poor mental health. So the first step is to develop a suite of brief interventions with different targets. So a health behaviour change intervention, a mental health-based intervention, and some combination of these two. And these are to be offered online with phone support by a clinician. Then after undergoing feasibility testing and consumer engagement, I will put these through a multi-arm trial, such as a factorial RCT, relatively large, I guess. And then the data set resulting from this larger trial will be used to examine factors associated with treatment acceptability and clinical response, both in terms of participant factors and treatment factors. So this will lead to two results or outcomes. One will be the knowledge to support the development of best practice psychological and behavioural care pathways for people with cardiovascular disease or elevated risk. And secondly, a comprehensive intervention package which can be offered on a digital platform, which reduces some of the significant barriers that people experience, such as cost, mobility issues, and lack of clinician time. So where is this up to, you might ask? So I've just finished developing the health behaviour change intervention, and it's about to go through feasibility testing. Thank you. So the takeaway messages, let's put it together. So there are some significant barriers to the use of health behaviour change interventions, with reasons both individual but also systemic. There is a need to consider mental health, which is not explicitly incorporated into interventions, despite its important role in clinical outcomes and adherence to important lifestyle changes. And therefore, future interventions should be optimised, both in terms of the health behaviour targeted, the type of condition perhaps, but also other characteristics such as the presence of mental health difficulties, demographics, preference, rather than assuming a one-size-fits-all approach. Thank you very much. Happy to answer questions later in the panel, or you can catch me after the presentations for a chat, or you can get in touch with me via email as well. Thanks.
Thank you, Andreea. Next up, I'm delighted to introduce Dr. Laura Yeates from the Garvan Institute of Medical Research. Dr. Yeates will be presenting on the Improve SCA study.
Thanks, everyone. I've only had that doctor title for a year and it's still like, oh, it's not me. It's really takes a bit getting used to, but if you're a PhD student, it's worth it. So keep going. So it's really a pleasure to be here. I'm going to be talking about a brand new study. I'm giving a bit of an overview and an intro to the study, hoping that I'll come back in next year and maybe even after that and give you further updates. So just bear with me. So the Improve SCA is an Australian national study improving outcomes and survivorship following sudden cardiac arrest in the young. And for this group, we're calling young anything under 50. So sudden cardiac arrest is a significant public health issue affecting around 3,000 Australians each year. But sadly, only 10% survive. And that's a figure, you know, when you look around the world and at all the different initiatives, improving bystander CPR and things, that number sort of holds true. And so we really want to try and move that survival rate up, but also for those families where the person doesn't survive, improve the care that they receive. When we look at causes of sudden cardiac arrest in this age group, over the age of 35, coronary artery disease really becomes the main player. But as a genetic counsellor that I am, I'm really also interested in the other groups, the non-ischemic cardiomyopathies, the other cardiac causes. Often these have a genetic basis, and so other family members are at risk. And so we are examining if we expect or if we suspect a sudden genetic cause to the sudden cardiac arrest. We like to lean on the chronic care model of care in these families to work out firstly the diagnosis on the left, whether that be via autopsy or if the person survives cardiac investigations, their pre-morbid investigations, and often the family history can give some really helpful information. We look to their management. How do we look after their family and screen their family, do genetic testing and cardiac investigation of other family members? And then thinking about the person who survives, but also the family, how do we support them? If they survive the cardiac arrest through rehabilitation programs, how do they return to work? But also providing psychological support for survivors and the family members of both survivors and the bereaved. So when we look at sudden cardiac arrest or sudden cardiac death research, Australia is actually a leader in this space. We were the first to describe, in fact, Richard Bagnall sitting in the audience was the first to describe that among 1 to 35-year-olds, the incidence of sudden cardiac death is 1.35 per 100,000, and that 40% remained unexplained after postmortem investigation. There's some great work coming out of Victoria from the Victorian Unexplained Cardiac Arrest Death Registry with Liz Peratz. They showed that 55% of young people who have an out-of-hospital cardiac arrest attended by an ambulance have a cardiac basis. There's this great initiative called AUSROC, the Australian Resuscitation Outcomes Consortia, which brings together all the ambulance services across Australia. We were the first to describe the psychological impact to families after sudden cardiac death, and that more psychological support is needed. And there's great work being done by Sonali Mano out at Westmead, looking at multi-ethnic communities and where there are gaps in knowledge and preparedness to do bystander CPR. We have a really strong patient and consumer voice with initiatives like NGCD, Heart of the Nation, which is run by the Yellow Wiggle Greg Page that's just joined with the Heart Foundation. There's some really great stuff going on, but there's still a critical lack in the coordination of care of these families. These top blue panel are some quotes from families who attended one of the specialised clinics here at RPA, just next door to the University of Sydney. And these are families who have attended a highly specialised clinic, yet they still, this is the guideline mandated care, they get the best that you can, yet they still describe the struggles that they have in trying to navigate the system, and talked about once they got to the clinic, they were well looked after, but prior to that, they were in this really period of a lot of uncertainty. One of the quotes at the top, the lady was talking about, I was trying to Google and read up on things, but I just felt muddled all the time when you're trying to do all this reading and upskilling in the midst of a grief reaction. And so whilst the international guidelines and evidence all talk about the multidisciplinary team, at the moment we don't have a unified system of care for how you access that team. If you die in, Broome, Western Australia, how do you access that team? Where does it lead? And so at the moment, that leads to gaps in care and health disparities where those with high literacy levels or a strong support network, if they have a friend of the family who knows a guy, who knows a gal, who knows a guy, then they might find the right place. And so we really want to get rid of some of those inequities so that everyone can access appropriate care. And so a couple of years ago now, in 2022, we all went to Canberra on a very cold, wintry day, as you do, for a national summit in sudden cardiac arrest. And cut a long story short, after that, this white paper written by Andreea Lagersh and a whole myriad of team members called for a national approach to how we look after this, and they've developed an initiative now led by Jamie Vandenberg, the Australian Sudden Cardiac Arrest Alliance. And one of the main outcomes of this meeting as a call for change was a method to address the lack of coordination of care. And so then from that group, we were able to submit a MRFF and were successful for this study, Improve SCA. So this will be a program of work that will result in a national virtual centre for the diagnosis, management and support of patients and their family members following sudden cardiac arrest in the young, with a goal to improve outcomes and survivorship. So our first aim is basically an environmental scan. We want to look at existing services and current guidelines and develop clinical pathways that also address the gaps that are currently there, making care equitable. In aim 2, we are going to co-design an intervention to respond to the sudden cardiac arrest family needs, incorporating clinical pathways and through hopefully a virtual network that will look at diagnosis, management and support. And then aim 3 is to conduct a type 1 effectiveness trial to make sure the intervention works. So just briefly for our environmental scan, we've established 11 working groups. The 5 in red are looking at various aspects of care, so diagnosis and clinical management, rehabilitation, family screening, psychological support and genetic testing and counselling. The ones in blue are feeding into each of those groups and providing how do we adjust that care for each of those populations. And then the 11th group recently added is approaching a sudden cardiac arrest registry. One of the challenges of our beautiful big country is that we are federally a country, but we have state-based health, which if you've ever had to do a national ethics, just really is like the worst. And so we are trying to approach, instead of forming state-based registries, which we have actually established in New South Wales and Victoria, as we go to take them to the rest of the country, we're sort of rethinking about, well, actually, how can we do this as a national initiative? So each of these groups are cracking on with lots of outcomes, particularly literature reviews to try and look at the lay of the land. We're also currently have a healthcare professional survey that's under ethics review that will hopefully go out later this year. If this is an area for you and you're interested in joining one of these groups, we welcome everyone, so just please get in touch with me. We want to make this really collaborative across the country. For aim 2, the co-design focus groups, we haven't got to those yet. Obviously, we need to do this after our environmental scan, but these will be focus groups with sudden cardiac arrest survivors, their family members, bereaved family members and healthcare professionals, not necessarily all together, but various combinations of those groups. And we'll be conducting co-design focus groups on various aspects of our intervention, basing it on the PRISM framework, which includes the RE-AIM framework, which might be one you've heard of, and then again, focusing on the chronic care model. We'll be doing iterative feedback and development to hopefully come up with our intervention. So in conclusion, Improve SCA is an Australian national initiative to improve the care of families after sudden cardiac arrest, regardless of the outcome. Our environmental scan is underway to identify gaps and disparities in care. We will then undertake co-design focus groups to develop an intervention to meet the needs. So more work to come. That QR code will take you to our brand new website. So if you want to have a look, yeah, you can contact us through that. Thanks very much.
Thank you, Laura. Our next speaker is Dr. Ritu Trivedi from the University of Sydney, and she will be discussing the potential of digital technologies to support patients with atrial fibrillation.
Thanks for having me this afternoon and giving me the opportunity to present on this research. So we know that there are various challenges in the management of CVD, and these will only continue to become more problematic in the future. And so there's already a lot of research that's gone into how we can cope with these challenges by addressing various aspects of the problem. But the part I want to focus on today is from the patient side of things. So when someone's diagnosed with a chronic health condition, it's a lifelong journey of learning, of adjusting, of managing. And when we think about this management, a lot of it is done by the patient. It's done in their home, it's done with their support network, it's done as them being part of a community. But there's still quite a lot of challenges and gaps that patients face when self-managing their condition. And so today, what I want to talk about is how can we support these patients outside of clinical settings? And I'm presenting on a study that I had the privilege to work on during my PhD, which looked at a novel digital health support program for patients that had been recently discharged from hospital with atrial fibrillation. So this program was a 6-month program. It consisted of 2 main components, the virtual visits and an educational website. So to start with the visits, there were a total of 7 delivered over the course of 6 months. They delivered different educational information on different topics related to AF, but also checked up on different aspects of the patient's atrial fibrillation related health. So these visits, so to say, they were delivered through automated phone calls with conversational AI technology. And what this meant was when a patient received a call, they would be delivered educational topics, but also asked about different health questions, and they would just respond using their voice. And it was like having a conversation with a friend or healthcare provider. If they weren't able to be reached by the phone calls, they were sent either a text message or an email, which linked them to an online interface, and they could complete the visit that way. The second component was the educational website, and this included sort of general AF information, but also information on medications, procedures, and risk factors as well. So what was in the virtual visit? So there were, as I mentioned, there was different topics we touched on, but also different questions we asked. So this here, we've got John, who has AF. He's recently been discharged from the hospital. And so 24 to 48 hours after he's been discharged, he receives his first phone call. And in this phone call, we remind him that he needs to book his follow-up appointment with his GP. Then 2 weeks later, he gets another phone call, and in this, he's asked about his symptoms, he's asked about his confidence in taking his medications, and if he's attended said follow-up GP appointment. And then a month after he's been discharged, he's asked about his medication adherence. And that's sort of the different topics and questions that we touch on in the other outreaches. So now if some of John's answers are concerning, so for instance, say he hasn't gone to his GP, or he's not taking his medications as instructed, or he's experiencing a lot of symptoms, we get notified and we're able to follow up with John to understand, well, what might have happened there. And so this is quite strategic in the sense that it's able to identify those patients that are quite high risk of deteriorating before they do. So we evaluated this program in a mixed method study with a randomized controlled trial. So we recruited patients with AF from Westmead Hospital Cardiology Services who were then randomized with a 4:1 ratio to either the intervention group or the control group. The intervention group received the program I spoke about, control usual care. We looked at a variety of different outcomes, but our primary outcome was looking at the change in AF related quality of life at 6 months between the groups. And we assessed this using a validated questionnaire called the Affect questionnaire. It's a 20-question instrument which outputs a total quality of life score. And that total score is made up of 3 subscale scores related to symptoms, to daily activities and treatment. Scores range from 0 to 100, 100 meaning limited disability from the condition. There's also another treatment satisfaction subscale score, but that's not part of the overall total score that's there. We also looked at a variety of other secondary outcomes, and this included self-management outcomes, healthcare utilisation, and health outcomes as well. But because this is a novel intervention, we were interested in process evaluation measures. Were people engaging with the program? Were they finding it useful? And as part of this, we also did some qualitative interviews to assess the barriers and enablers to using such a technology for self-management of AF. So before I move on to the results, unlike any other trial, there was a hiccup where the technology partner that was providing the intervention was acquired by a larger organisation, which meant they withdrew their services and we had to stop recruitment. So not fun part of the PhD. But how we coped with this, we had to essentially develop a solution to get the remaining patients that were a part of the intervention to complete the program. So we developed the intervention on REDCap, and instead of the phone calls all the participants received in the intervention arm, received the remaining outreaches on the online interface instead of the phone calls. And so at the end, so it was essentially, actually, I should mention, it was the same content. The delivery mode had just changed from the phone calls to the online interface. So at the end, we'd recruited about 103 participants, 21 controls, and 82 intervention participants. The average age of the cohort was about 64 years old and 30% women. When we looked at the results, there was no significant change in the primary outcome, so no change in total quality of life scores at 6 months between the two groups. And we also didn't see any changes in the individual subscale scores either. But when we looked at the pre-post analysis in the intervention group, there was a significant difference, and this wasn't seen in the control. However, keeping in mind that this analysis is significantly underpowered and the control group only has 21 participants, so it's really difficult to make any solid conclusions on what would have happened if we had a powered analysis here. But similar trends were noticed in the 3 subscale scores that made up the overall quality of life score. So we saw improvements from baseline to 6 months in the intervention groups, but not in the control. No changes were seen in the treatment satisfaction. I haven't presented the secondary outcomes here, but as I mentioned, we looked at self-management outcomes as well as health outcomes and healthcare utilisation, but there were no significant differences between groups in any of those. Interestingly, though, we did find some interesting results in looking at process evaluation measures. So really looking at, well, how did participants interact with the program? Were they answering the calls? Were they completing them? Did they find them useful? And what we see is engagement is quite high in the first 3. So that's the first month that the phone calls happened. It's pretty high there, but then it drops off over time. And towards the last phone call, the visit, it's less than 50% of people completing them. But what we do find is that satisfaction is consistently high, so it's always above that 80%. So the people that are engaging with the visits are finding them useful. So to conclude, this pilot study does provide us with some initial data on the efficacy of such a novel digital health follow-up strategy leveraging conversational AI. And it does show some initial promise in improving health-related quality of life in the intervention participants that receive the program. But this is difficult to tell with sort of the limited power that we had for the analysis. We found that the engagement was quite high in the first month, but then it dropped over time. And although we still had quite high satisfaction consistently throughout the program of those that were completing the visits. So future directions, next steps, where we've partnered with another technology provider to redevelop the CHAT-AF intervention, and it's currently been evaluated in a multi-centre trial, which I believe has recruited around 480 participants, and it is now powered to detect differences in its primary outcome. So stay tuned for those results. That's quite exciting for us to have done that. And that's it from me. Thank you.
Thank you, Ritu. Our next speaker is Dr. Kaylee Slater, also from the University of Sydney, and she'll be presenting on lack of validated blood pressure devices for use in pregnancy. Welcome, Kaylee.
Thank you. So hypertensive pregnancies are a group of pregnancy complications that affect both the mother and the baby in the immediate term, but also the long term. And approximately 10% of pregnancies worldwide are complicated by hypertensive disorders of pregnancy. So the hypertensive disorders are chronic hypertension, gestational hypertension, and then also preeclampsia and eclampsia. And after a pregnancy that has been complicated by hypertension, up to 50% of these women will go on to develop chronic hypertension. And there's also an increased risk of other cardiovascular disorders, so cardiovascular disease, but also stroke and heart failure. So when it comes to home blood pressure monitoring, our Australian guidelines, which are also in line with the international guidelines, suggest that in women with gestational hypertension or chronic hypertension, that they can actually monitor their blood pressure. They must use a validated device, and they must also have appropriate counselling from their clinician in order to know how to monitor. However, the monitoring that they do at home should not replace the minimum frequency of their antenatal reviews. So they should still be going to their doctor to have their blood pressure measured and all of their other antenatal appointments. However, the compliance, so whether they're actually complying with the home blood pressure monitoring, but also the technique, so that the way they're monitoring should be reviewed at every single one of their visits if they are going to be using home blood pressure monitoring. Now, when it comes to the actual blood pressure device, blood pressure devices that are used in pregnancy and for preeclampsia should actually undergo additional validation to the validation that's done in the general population. And that is because during pregnancy, there can be some hemodynamic changes that can actually make the blood pressure monitors not as accurate. So it means that in order for these blood pressure monitors to be validated, they have to go under additional validation, so there's less availability of these devices. What we also know is that 30% of women during pregnancy are actually monitoring their blood pressure. And blood pressure monitoring at home can actually be used to help diagnose, but also to help manage hypertension during pregnancy. So the purpose of the study was to understand that when Australian women are going to the pharmacy, can they actually buy devices that have been validated for use during pregnancy? And in doing so, we wanted to also understand whether these devices cost more than devices that either weren't validated or were validated in the general population, and also whether when pregnant women are buying these devices, do they actually know which ones are validated for use in pregnancy or not? So we did a Google search to basically find some pharmacies that were selling blood pressure devices, and we found 18 pharmacies. In order to actually extract the device cost, we made sure that the pharmacies we found had to have both physical but also online stores in Australia. So the data that we extracted information on the device make and the model. We also extracted the device cost, and across the pharmacies, because a lot of the pharmacies sold many of the same devices, we just took the lowest cost on the day that we did the extraction. And we also extracted information on, I guess, labeling for pregnancy. So any warnings to use or not to use the device. In order to understand whether it was or wasn't validated, we used STRIDE BP. So STRIDE BP is a joint initiative between the European Society of Hypertension, International Society of Hypertension, and World Hypertension League. And it's also independently run by hypertension experts. And the purpose of STRIDE BP or the website is to help clinicians, but also patients understand whether their devices are validated for use, among other things that they do as well. So if the device is listed on STRIDE, it means that it has been validated for use. And you can see in the second, I guess, dot point, this particular one was validated in, general population in adults, but also in pregnancy and preeclampsia. So when it comes to the devices that we found 49 upper arm cuff devices and 5 wrist cuff devices. So we found 54 unique devices altogether. And among those 54 devices, only 4 of them were validated for use during pregnancy. Now, when it comes to, I guess, availability of those devices, of the 18 pharmacies, 16 stocked at least one device that was validated for use during pregnancy, meaning that 2 of these pharmacies did not stock any devices that were validated in pregnancy. 4 pharmacies stocked only 1. 3 pharmacies stocked 2. But 9 pharmacies stocked 3 devices that were, or 3 of the 4 devices that were validated for use during pregnancy. None of the 18 pharmacies stocked all 4. Now, when it comes to cost, the median price of the devices that have not been validated in pregnancy or the general population was 90 Australian dollars. The ones that had been validated for use in the general population, but not in pregnancy, were a bit more expensive at 137 Australian dollars. But then when it comes to the devices that have been validated for use in pregnancy, they were quite a lot more expensive. So the median price was 199 Australian dollars. Now, when it comes to, I guess, labeling or helping pregnant women actually choose the device, 16 of the 54 devices listed some kind of caution warning for use during pregnancy. 5 of them stated that they were suitable for use during pregnancy, and 33% of them had no mention of pregnancy whatsoever. So going back to the 16 that listed a caution warning, 4 of them stated that they had not been tested for use during pregnancy, so people should not use them during pregnancy. But then 12 of them stated to see a health professional before use in pregnancy. All of this information was actually in the device manual, not on the website or the device kind of website, so not the pharmacy website or the device website. And when it listed to see a health professional, this was, I guess, a general warning of a variety of different conditions. So things like diabetes, atrial fibrillation, other heart conditions were in there as well. So it wasn't, I guess, taken out saying don't use this if you're pregnant. But amongst these 12 that stated to see a health professional, 2 of them actually had been validated for use in pregnancy. Now moving on to the 5 that stated that they were suitable, only 1 of these devices was actually validated for use during pregnancy. And then of the 33 that didn't have any mention of pregnancy at all, only 1 of these devices was validated. And like I mentioned before, all of this information was actually in the device manual. There was no information at point of sale, and there's no information on the actual device box. So when people go to the pharmacy to choose their device, this information wasn't there. So I guess some of the take-home messages is that the majority of the blood pressure devices on the market that are sold in Australian pharmacies are not validated for use during pregnancy. However, most pharmacies do actually stock at least 1 device that is validated for use during pregnancy. But we really need some improved labeling and also education. So if pregnant women are going to the pharmacy and they're actually choosing a device, it's really important for them to know which ones have and have not been validated for use in their population. But it's also important for the clinicians, but also the people that are selling these devices to be able to point these pregnant women in the right direction, because especially if the devices are so much more expensive and they don't even know that they have been validated, why would they choose them? So yeah, thank you, and thank you to my co-authors.
Thank you, Kaylee. Our final EMCR speaker is Dr. Vrushali Chimankar, who will speak to us about the role of loss of Y chromosome in hypertrophic cardiomyopathy. Welcome, Vrushali.
Thanks, Sabine, for the introduction and also for having me here today. So hypertrophic cardiomyopathy is an inherited heart disease affecting around 1 in 500 individuals. The clinical outcomes can range from mild or no symptoms to heart failure and sudden cardiac death. Now, although HCM is mostly genetic, up to 40% of the cases have no known cause of HCM, suggesting an involvement of other mechanism for the pathogenesis. So here's where the mosaic loss of Y chromosome come into the picture. It's the most commonly acquired somatic variation in leukocyte involving post-zygotic loss of Y chromosome. Approximately 1 in 5 men over the age of 80 years will show some degree of loss of Y. For the longest time, it was considered to be a neutral event linked to aging, but now there are several epidemiological studies that have showed that mosaic loss of Y chromosome is actually associated with reduced survival, different types of cancer, Alzheimer's, schizophrenia, etc. It is very important to note here that most of these diseases are prevalent in men as compared to that of the female, raising a question if mosaic loss of Y chromosome is one of the contributing factors in all of these diseases. Now, the risk factors range from aging, then smoking, air pollution, and genetic predisposition. In case of cardiovascular diseases also, there are several studies that have shown the involvement of mosaic loss of Y chromosome. For example, a study in aortic valve stenosis showed that the patient showed up to 83% loss of Y chromosome. Again, in study in atherosclerosis, approximately 17% of the patients showed mosaic loss of Y chromosome. In a study of atrial fibrillation, men with mosaic loss of Y chromosome had almost twice the incidence of AF as compared to those who did not have any loss of Y chromosome. Similarly, a UK Biobank study actually showed that men who had a prior diagnosis of stroke and heart attack showed 3% mosaic loss of Y chromosome. So the first mechanistic study to actually show that there's a link between mosaic loss of Y chromosome and cardiovascular disease was actually conducted in a mouse experiment, wherein the CRISPR-Cas technology was used to target the Y chromosome. When this was done, the resultant mice actually showed shorter lifespan, accelerated development of age-associated cardiomyopathy, and increased cardiac fibrosis. Now, these studies have also shown that the mosaic loss of Y chromosome causes increased cardiac fibrosis, dysregulated immune function and immune system, as well as dysregulated gene expression of the genes not only involved on Y chromosome, but also on other autosomes and X chromosome. And these form the basis of my hypothesis. Now, since persistent cardiac fibrosis and inflammation are the key players in HCM, we hypothesized that the mosaic loss of Y chromosome may contribute to the HCM pathogenesis by promoting fibrosis and immune function dysregulation, potentially explaining the part of missing heritability in the cases that are not linked to the genetic variants. The aim of the study are to determine the incidence of mosaic loss of Y chromosome in HCM across different age groups and clinical subtypes, and to assess the impact of the loss of Y chromosome on fibrosis and immune function in our HCM cohort. Now, this slide shows the workflow and the output of the digital droplet PCR that I used to detect the mosaic loss of Y chromosome. Firstly, we do the DNA extractions from the samples that were collected. Now, the key step in digital droplet PCR is actually generating the droplets. So what the droplet generator does is it partitions one entire sample into 20,000 droplets, each having different fragments of your DNA. So instead of having one tube with one reaction, you essentially have 20,000 reactions in one single tube, making this technique really, really sensitive. Then you do any standard PCR, but here we use a specialized Stackman assay that can distinguish between X and Y chromosome based on the 6 nucleotide differences between the region on X chromosome. It also has a probe, 2 probes that specifically bind to the region on X and Y chromosome. For example, here, the Vic probe binds to the X chromosome and emits a green fluorescence, whereas the FAM probe binds to the Y chromosome and emits a blue fluorescence. So after the digital droplet PCR is done, you get this 2D amplitude. And as you can see here, because this person, the sample, had X and Y chromosome both, this is what it should look like. Now, we divided our cohort into 4 different groups. The control groups were the people who were clinically unaffected family members of people who were of patients who had HCM or any other cardiovascular disease. The HCM patients, as the name suggests, were the people who were clinically diagnosed with HCM and also had symptoms of HCM. The third group is asymptomatic HCM family screening group. Now, this group actually involved the family members of HCM patient who were asymptomatic but were only diagnosed because they were screened. The last group is asymptomatic HCM incidental group. Now, these are the people who are asymptomatic and they were actually diagnosed with HCM because they went to the hospital for some unrelated condition. So now, since age is the biggest risk factor for loss of Y chromosome, we tried to find if there's an association. We saw that there is a steep increase in the loss of Y after the age 60. Therefore, we divided our groups, each group into 2 age groups, one under 60 and the second one above 60. Now, this is our control sample. And as you can see, in the patient below 60 years of age, there is a slight increase in the loss of Y with aging, but however, it is not it is borderline significant, and the correlation is very weak. Whereas patient above 60 years of age, you see that there is a massive increase in the loss of Y with aging. However, again, the significance was not that statistically significant. In the case of people who were from the HCM group, unfortunately, we do not see any association. The correlation is very weak or almost close to no association. For individuals belonging to the asymptomatic HCM family screening, we actually see an inverse association of age with mosaic loss of Y chromosome. Again, the correlation is very weak and not that strong. However, in this last group, where we included the asymptomatic HCM patient that were incidentally diagnosed, you see that in the age group above 60 years, you actually see a strong association with mosaic loss of Y chromosome and aging, suggesting that in this group, age is a contributing factor. Now, I want you guys to focus on these two individuals from the asymptomatic group. They show a 100% loss of Y chromosome, so we decided to investigate these further. I did a simple PCR experiment where I designed the primer for AMELY gene. Now, this was a gene that is also used in digital droplet PCR, and as a result show both of this individual do not show any amplification for this gene, which is fine because that's what we see in the digital droplet PCR anyway. So next, I decided to do a sex PCR, which involved primers designed for X and Y regions X and Y genes specifically. And here you can see that the individual who belonged to the asymptomatic HCM family screening group did show an amplification of the X region, X chromosome, but not for the other one. And it looked very similar to that of the female control. So this suggests to me that maybe we had like a sample mix-up and there's not actually a loss of Y chromosome here. In this patient who belonged to the asymptomatic incidental group, you see that there's an amplification for both X and Y chromosome, as you can see for any normal male, which actually suggested that maybe this patient had loss of or a deletion of the AMELY gene and not the other gene. Fortunately, we had the exome sequencing data on this patient, which showed that this patient had a deletion of the AMELY gene and most other genes on the Y chromosome were intact. So this actually shows us that it was a gene-specific loss and not the loss of the entire Y chromosome. I had a quick look at the genome aggregation database, which showed that 1 in every 183 individual of South Asian ancestry will show a deletion in the AMELY region. And this individual also belonged to that South Asian ancestry, so which kind of proved the thing. So in summary, we can see that there's a steep increase in the loss of Y chromosome after 60 years of age, and it is consistent with the literature in any other disease. The asymptomatic HCM incidental group did show statistical significant increase in the loss of Y with age. However, the control group did show a small trend towards increase in the loss of Y with age, but however, it was not statistically significant. So for my next step, I would really like to investigate the association between the mosaic loss of Y chromosome and clinical severity in our HCM cohort. And I can do that because we have data on the ECG and echo, as well as the genetic variants for these patients. So I can do that. Secondly, I would like to assess and analyze the RNA sequencing database, that the publicly available RNA sequencing database, and to see if that database also shows any degree of loss of Y chromosome. And if they do show any loss of Y chromosome, I would like to investigate if they also show a marker for cardiac fibrosis and inflammation as seen in other cardiovascular diseases. The limitation of this study would be that the sample size was very unevenly distributed. And the second was that we are really limited by the use of pre-existing samples and the data that were available in the lab. I would really like to thank my team Cardio, for helping me throughout my progress. My supervisor, Associate Professor Richard Bagnell, for helping me with the project. Jackson, who's helping me with like DNA extractions and just a day-to-day experiments. I would also like to thank Jessamy Tiffin, who is from Centenary, who's also working on a project on mosaic loss of Y chromosome and melanoma. Chirag, who's helping me with the bioinformatics, and Jeremy Crook and his entire lab for allowing me to use the digital droplet PCR platform. Thank you so much.
Thank you, Vrushali. Up next is Joan Ma from the Victor Chang Cardiac Research Institute, and Joanne will be presenting on the classification of Brugada syndrome.
Having me. So I'm Joanne, and I'll be giving you an overview of my phenotyping assay for Brugada syndrome. Title. So Brugada syndrome is an arrhythmia that's characterized by ST elevation on the ECG. It affects approximately 1 in 2,000 individuals, primarily males, and it can be inheritable. SCN5A is the only gene associated with Brugada syndrome in the clinical setting. SCN5A it encodes for the voltage-gated cardiac sodium ion channel, and the passing of sodium ions through this channel is measurable by the sodium current, which is responsible for the depolarization of the action potential. Variants associated with Brugada syndrome influences our sodium current, which in turn increases our action potential notch and the ST elevation on the ECG. SCN5A variants can have a range of effects on the sodium currents. Here are a few example traces ranging from normal current to severe or complete loss of function. SCN5A variants can be classified ranging from benign to pathogenic variants based on their likelihood of causing disease. And if you detect a likely pathogenic or pathogenic variant in your patient, it generally it would instigate familial screening. But the problem we have at the moment is that a lot of our SCN5A missense variants are classified as variants of uncertain significance due to insufficient data. So the aim of my project was to develop a functional assay that is high throughput and can be used in the clinical setting. And this is the results of my assay. Our collaborators at Garvan curated a list of variant controls that are known to cause disease or known to not cause disease. And as you can see, my assay can differentiate between most of my pathogenic variants from the benign variants. So the benigns are in blue and the pathogenics are in red. This assay is graded by the severity of the loss of function and was validated according to ClinChang guidelines. So my next aim was to see how we can apply this assay to the variants of uncertain significances, or what our problem is. And so here we have 252 variants that were found across over 450 Brugada syndrome patients, and we screened these variants, half of them by myself, half with collaborators based at Vanderbilt University Medical Center. And as you can see, there is a large range of function amongst these variants. And this is what the variants are within the sodium channel protein, colored by their degree of loss of function. And then to determine the utility of this assay, I reclassified variants, or I applied evidences, pre and post classification, to see how we can reclassify, how many VOSs we can classify, and found that we can reclassify just under 50% of these variants. Thank you for listening.
Thank you, Joanne. Our last and final speaker is Aileen Zeng, who will speak to us about the impact of remote care technologies on burden of treatment in cardiovascular disease.
Thank you for the opportunity to present today about my PhD research. So my PhD focuses on a novel patient-reported outcome called treatment burden, which is defined as a patient's perception of the aggregate weight of the actions required for their healthcare. This concept is particularly relevant to cardiovascular disease, where patients often face long-term treatment plans involving medications, lifestyle changes, and self-monitoring. These tasks, while essential, can accumulate and contribute significantly to treatment burden, as you can see illustrated on the left and often seen in my patients as an allied health clinician. Importantly, treatment burden has also been identified as an independent predictor of quality of life, which is a key patient-reported outcome measured in a lot of clinical trials and considered in patient-centered care. My PhD, which focuses on digital health aims to address the evidence gap around how mobile technologies can impact treatment burden in cardiovascular disease. Today, I'll briefly present 2 studies from my PhD research program. On the left, you can see Educate MI, which aims to assess whether a 5-minute multilingual educational video provided to patients hospitalized after myocardial infarction or MI can improve their patient knowledge on MI. This video focuses on medications required post-MI and also the pathophysiology. We found that the video improved patient knowledge of MI short-term, and given that patients report high treatment burden 1 year post-MI, videos can be potentially used as a primer for adherence for secondary prevention strategies. The video, I must say, also is available in English, Hindi, Mandarin, and Arabic. On the right, we have a systematic review and meta-analysis that aims to assess the effects of digital patient decision support tools for AF treatment decisions. We found that digital patient decision support tools can facilitate shared decision-making by improving patient knowledge and reducing decisional conflict. You can see the full paper in the QR code on the bottom left. Given the complexity of AF treatment options, these tools can help align patients' values and priorities and potentially reduce treatment burden in the long term. These 2 interventions are examples of how we can design digital tools to potentially mitigate treatment burden in the long term. I'd like to acknowledge my supervisors for their continual support and happy to chat about my research via email. Thank you.
Thanks, Aileen. So that brings us to the end of the talks. If I can have all the speakers down here at the front for Q&A panel. Yeah. Okay, do we have any questions? Yeah, Peter? Yeah.
Question for Vrushali.
Yes.
Sorry if I
No,
pronounced the name
no.
wrong. Yeah. So you mentioned like the loss of Y chromosomes happens in the leukocyte, right?
Mm-hmm.
So what about the other cell types, especially those ones related to the cardiovascular disease? Like for example, I know like a platelet red blood cell, they don't have
Yeah.
nucleus, but what about like for example the smooth muscle cells?
I don't think so there's
This-
any, because it's very new. I mean, all the latest paper have come from like 2023. It's very new field. So most of the papers have only looked into leukocytes, like from blood samples. They haven't actually looked into like other cells, as far as my knowledge for now. Yeah. But
even not
when,
like the other red blood cells, like neutrophil.
yeah. Actually, neutrophils, yes. But I don't think so. They've studied it in cardiovascular disease. For example, neutrophils is actually loss of Y in neutrophil is linked to atrial fibrillation. If I'm not sure, wrong, prostate cancer as well. But yeah. Yeah.
Oh, yeah, sure.
Just take it.
On that note, so I noticed you use blood-derived PBMCs. So they're and forgive me, I'm not a basic scientist, but my understanding is they're quite immature as heart cells. Your loss of Y chromosome increases with age. Do you think that's like a contributor to the results that you found not showing an effect because you're using premature cells? Like if they're like a premature, help me out, Richard, what's the term I'm looking for? Like an infantile cardiomyocyte.
Yeah, we are not.
What have you used?
Yeates.
PBM. Oh, okay, I am. I was so confused. Okay, thank you. That's why you ask questions.
Any other questions from the audience? If not, I've got a question. Oh,
I have
do you want to?
Ritu.
Yeah.
You go first.
Yeah, I've got a question for Ritu actually. Seeing as readmissions is quite a significant burden for AF, so what was the rationale, I guess, of choosing quality of life as a primary outcome for CHAT AF trial?
Yeah, great question. We did look at some healthcare utilization data. So we looked at if they had come, if they had been come into ED at any point in the 6 months that they were enrolled, or the 6 months into trial period. Well, again, we didn't see any significant differences. But I hope that with the larger sample size, with the new trial, we're able to sort of really see if there's going to be significant differences in healthcare service utilisation. So, you know, how many times they're going to see the GP, how many times if they're coming into ED or not, if they've been hospitalised for any risk, because it's very important. It's a large contributor to the healthcare system costs. The reason we chose quality of life specifically was it was a all-encompassing measure. When it comes to atrial fibrillation, it's a chronic health condition. There's a lot involved, from medications to symptoms to adhering to lifestyle changes. So quality of life was one of the factors that we thought we could look at to then really see if an educational management intervention would really improve that. Yeah.
Okay, thank you. One last follow-up before I give you the microphone, Laura. So for Ritu, actually, still, seeing as you recruited, I guess, you know, in Westmead, which is very culturally and linguistically diverse area.
Yes.
So the technology, was that only in English, or was it translated in other languages as well? And I guess, how did you manage recruitment in,
Yeah, that's a great question. You know, as you mentioned, that Westmead Hospital is in Western Sydney, and it serves a ethnically diverse, culturally diverse community. Unfortunately, because this was a pilot, it was only delivered in English. We tried to, the phone calls themselves were done by a trained actor, so the language, the English was relatively neutral, or it was adapted to work for the Australian context. But in terms of cultural adaptations, language, we weren't able to do that at this stage. But I think it's an excellent point you raise. Given the population, it's important that we're able to create these tools that are going to work for the diverse populations that we have in Sydney.
Okay, thank you.
Thank you. I was wondering about your app. Like, I get this app, like this person who calls me selling wine, and I think that they're a computer, right? But I can't prove it. Did the patients, do they know it's a computer, and did they respond well to it?
Yeah.
And does it have like a script? So I try and trick the wine person that calls me, but did they try to trick it?
Great question. So from the qualitative interviews, interestingly, we found that because the program was delivered through a hospital, there was a sense of trustworthiness that they found from, they thought that, okay, well, this is not just a robocall. It's because it would start off with saying, hello, hi, John, this is the Westmead Hospital atrial fibrillation program calling to check up on you. So having that hospital attachment, or a reputable institution organization attached to it, and coming from a hospital of, you know, their cardiologist would be there, or they've obviously come into the hospital for some reason. So having that actually created a sense of trustworthiness with the intervention, which was very interesting.
And then did you find a way to test, you know how they say that people like underestimate their alcohol intake, for instance?
Yes.
Did you find a way to test compliance, like in the validation of this app, probably prior to your study? But I assume like you need to make sure, how do you account for people overestimating or underestimating their compliance, or do you just take it at face value?
Yeah, it is self-reported. So a lot of the questions that were asked are self-reported. So you sort of have to take it. Well, and you hope that patients would understand what we're doing here is sort of checking up on them. So hopefully they would answer honestly. But we didn't sort of look at anything in that detail. Yeah. There's interesting studies that look at medication adherence using, they'll have bottle caps, which track every time the bottle's been opened. So that's sort of an objective way to look at self-management behaviors. Yeah.
Do we have any questions online? No? Any questions here on the floor? I've got a question for Andreea if no one's have any questions. So I guess you looked at varied socioeconomic status in that survey as well. Did you see, I guess, any sort of differences in the barriers and uptake to the health behavior change interventions?
Thanks for that question, Sabine. So I did look at socioeconomic status, and actually that wasn't significantly associated with uptake or with interest in future intervention participation. However, for the mental health, interest in future mental health intervention and interest in a future combined intervention, Australia is country of birth and what was it? There was one other demographic characteristic. Higher education were significantly associated. So obviously there are some kind of demographic differences there, but not socioeconomic. And the sample that I had did have a lot of socioeconomic status variations. So it did actually match the Australian kind of distribution. So yeah, interesting.
Yeah. And a follow-up question. So you talked a little bit about personalization of behavior change interventions. What does that look like? I mean, in reality, we're all different. So in terms of personalization, do you have any thoughts on that?
I do, yeah. While I'd love to say that, it's this really like everyone gets something really different. And I think what I'm aiming for, I guess, is, people might go to their doctor, they might, find out they're at increased risk of cardiovascular disease or have cardiovascular disease already. And based on some of their characteristics, their doctor knows where to send them off to, I guess, like knows whether they'd be better off doing a mental health intervention that has some chronic disease kind of stuff incorporated in it, or a behavior change intervention, or maybe the sequencing, they need to do one, then the other. So maybe it's not about, just having an intervention for each person, but at least knowing based on some characteristics where you can send people off to. Yeah.
Okay, thank you.
Yes.
I also have a follow-up question, but going in a different direction.
Okay.
You mentioned some systemic variables, but the systemic variables that you mentioned were things like being referred by a GP, which are less systemic than I would consider systemic variables. I wondered if you've considered things like green space and access to public transport and things where you can time to do physical activity is often an issue, but if you can turn it into commuting, then it can work better than trying to find extra time. So, but that only works if you live close to public transport, for example. So have you considered more systemic variables?
Yes, I have. Thanks for that question. I'm very passionate about that issue. And I actually did ask people specifically about access to space they could do physical activity, cost related to kind of diet, healthy food and so on. And that actually wasn't very few people endorsed, especially the cost one regarding food was a little bit higher, but access to places to exercise wasn't particularly marked. I guess what I meant by systemic is more embedded in the health system. So it is a problem that healthcare providers are not, and the report by the Sachs Institute, which I quoted in my, cited in my presentation, shows that people are not being referred to these interventions by their GPs. So yeah, I meant more factors that are not within the individual. Yep, but those are really important, yeah.
Thank you. Any other questions? Okay. Last one.
Hi, I had a question for Joanne and your SCN5A work. I was curious to know, of the variants that were sitting in the likely pathogenic realm in your assay, did they tend to cluster throughout the SCN5A gene, or like in certain hotspots, or was it just scattered throughout?
Yeah, so I think it was my last slide in the middle panel. That's the entire protein, the sodium channel protein. And we do see a lot of the pathogenics clustered around the pore region primarily, but mostly in the transmembrane region, whereas most of our benign variants were sort of outside in intracellular loops and stuff. Yeah, so
Last one, last one.
Thank you. I've just got a question for Kaylee, if you don't mind. I find your research quite very, very interesting to me, and just more like comments from your experience after, I guess the study has been published. Not yet. Okay. Yeah. Okay. So, well, I felt like after, if you had said yes, then that probably would have led to my question. But it's more like a thought around, when you get it published, I feel like it's going to create a lot of awareness in terms of, pharmaceutical companies and also manufacturing companies to do like validation studies. So, but, that's what I thought. Thank you.
Thank you. Okay. If there aren't any more questions, I think I will let you guys off the hook. Please join me in thanking all of our speakers today for their insightful presentations, and also thank you for joining today's seminar. So the next and final CVRN Rising Star seminar is in September at the Victor Chang Cardiac Research Institute, and we are hoping that you could also join us then. And to wrap up, it's not moving for some reason, but there is a QR code slide which we will leave up. Oh, it's at the door, yeah. For any feedback that you guys might have, and we'd really appreciate your thoughts on how the seminar is being run. Thank you, Siki. And for those here in person, please join us for some networking and drinks. And if I can have all the speakers here at the front just to take a photo, and I'll present you with your certificate as well. Thank you, everyone.